Hello, ladies and gentlemen. This is a continuation of our discussions and lectures on anesthesia. In this presentation, we are going to talk about additional anesthetic drugs, and we're going to spend a little time talking about pain, although we'll have a much fuller discussion of the management of pain in a future lecture. So what is pain? The International Association for the Study of Pain, IASP, defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So when we talk about pain, we often talk as if something had been damaged, even when we don't know that that in fact has happened. So these are some of the subcategories that the IASP has defined, and I'm not going to go through all of these. You can look them up if you wish, but it's a very complex, extensive list of subcategories of pain, and there are variations in treatment depending upon which type of pain an individual suffers from. We're going to talk in more general terms about pain. So the IASP states that about 30% of humans suffer from chronic pain at some point in their lives. And chronic pain is pain that lasts for greater than 3 months. Some people say greater than 6 months. They further go on to say that about 7% of people are completely incapacitated by chronic pain. It's the most prevalent cause of disability that we have in healthcare. Greater cost of disability than cancer and heart disease combined. It's universal. It's a human characteristic that exists in every one of us. Perception of pain is not modified by ethnic background, but presentation of pain is affected by the culture from which you come. And let me give you an example of this. I often teach anesthesia residents in Uganda, and one of the things I noted the first time I went to Uganda was how unbelievably stoical Ugandan people are. They never complained about pain. They never asked for drugs. The amount of pain medication given was minuscule. And I thought this was odd because my understanding was that we all feel pain the same. It didn't matter what culture we were in. So I did a little study where we actually went and saw patients post-operatively, and we asked them to provide a pain score. 0 for nothing, up to 10 for absolutely excruciating pain. And what we discovered was what I expected to discover, is that Ugandans, like everybody else in the world, have pain, and they have pain at about the same level as everybody else. But culturally, it's not really acceptable for them to show pain. Stoicism is expected. The reality is they suffer pain just like the rest of us. Surgical pain is acute pain, but we must discuss chronic pain, and we will discuss chronic pain in a future series of slides. So pain is not a benign process. Cardiovascular and respiratory systems are significantly affected by the pathophysiology of pain. There's dramatic adrenergic stimulation. This is release of norepinephrine throughout the body and from the adrenal gland. Hypercoagulation can occur, leading to disseminated intravascular coagulation. Heart rate goes up, cardiac output goes up, myocardial oxygen consumption goes up, which can lead to myocardial ischemia or myocardial infarction. Pulmonary vital capacity drops because, particularly if you've had an injury to your chest or surgery to your chest, you splint your muscles and you can't breathe deeply. And this can lead to alveolar hypoventilation, reduction in functional residual capacity, atelectasis, pneumonia, and serious problems with arterial hypoxemia throughout the body. Also, pain suppresses immune function, predisposing trauma patients particularly to wound infections and sepsis. So what are analgesics? In Wikipedia, analgesic is defined as a painkiller and any number of these groups of drugs used to achieve analgesia, relief from pain. It derives from Greek, and the analgesia was without pain. So an analgesic is something that prevents pain. Obviously, Gesia was pain. Analgesic drugs act in a variety of ways on the peripheral and central nervous system. Some classes of drugs have no central effect at all. Others have little or no peripheral effect. They are distinct from anesthetics, which reversibly eliminate sensations, and they include such drugs as paracetamol, known in North America as acetaminophen, or simply as APAP, and the non-steroidal anti-inflammatories, NSAIDs, such as salicylates, and opiate drugs such as morphine and opium. Additionally, other drugs such as antidepressant drugs, anticonvulsant drugs, and some anesthetics at subanesthetic doses can also can relieve certain kinds of pain. So we talked about nitrous oxide and ketamine previously. So in general, in most parts of the world, nonsteroidals and salicylates are non-controlled drugs. And opiates are controlled drugs right across the world. There's actually an international convention that controls these drugs. Other analgesic drugs are usually provided by prescription only, again, depending on where you live. Opioids work centrally in the brain and spinal cord to reduce perception of pain. So they work at every level of the central nervous system and the peripheral nervous system. They're either derived from naturally occurring alkaloids, opium from opium poppy, and these are opiates, or they're chemically derived, and they're called opioids. I'm going to use these words interchangeably because they mean the same thing in essence. It just is an indication of where they come from. They're similar in structure, although it's interesting when you look at them chemically, they don't really look very much alike, but they all have one common feature. They have the ability to bind to opioid receptors in the brain and spinal cord, as do enkephalins and endorphins, which are naturally occurring opiates which we produce within our bodies. These are the most effective drugs for relief of acute pain, surgical pain, trauma pain. They all create tolerance, and they create tolerance in 100% of us. They all create physical dependency, and they create physical dependency in 100% of us. They all have the potential to create addiction. All are controlled to drugs, but the incidence of addiction is actually quite low in people who use opioids, even though tolerance and dependency are very common. They all produce nausea and vomiting, itching, constipation, and funny feelings, emotional feelings. Dysphoria, we call it. It's hard to describe. Just an unpleasant general feeling. They can all cause muscle rigidity, which is something you probably will never see unless you're giving high doses of these drugs during anesthesia. I've certainly seen it, and it's very profound. They all have respiratory depressant effects and can cause death from hypoxemia. The comments, when you hear about somebody dying from an overdose of opioids, it's nearly always a respiratory arrest that is the initiating factor in then the ongoing development of cardiac arrest and death. So there are a huge number of opioids out there, and they vary by potency, duration of action, mode of absorption. Some of them tend to be very short-acting and have less profound effect on respiratory depression than others. Others are very slow in onset, have very long actions, methadone being the classic, and don't produce the dysphoria that addicts seek when they seek narcotics. So morphine, heroin, meperidine, or Demerol was or pethidine in most parts of the world actually, codeine, oxycodone, hydromorphone, fentanyl, sufentanil, which is 1,000 times more potent than morphine, and is only used by anesthesiologists, L-fentanyl, remifentanil, which is very short half-life, about 1.5 minutes, and again is only used by anesthesiologists. And they have a very wide range of delivery methods. You can think of almost any entry to the body, you can give an opioid by that entry. So how do we deal with some of the pain issues associated with surgery? One thing we can do is we can put in an epidural, and I'll speak more about the difference between epidural and spinal in a future lecture. But let's, at this moment, just talk about putting in an epidural, which is placed before surgery. We put a catheter in, and we use a pump like this, not necessarily exactly like this, to inject usually a combination of local anesthetics and opioids. And this can produce profound pain relief, particularly for patients who've had thoracic surgery, which is very painful, or abdominal surgery, which can also be very painful. For less severe types of pain, we often use patient-controlled analgesia. And this is an example of a fairly old pump that we used in our hospital. And you can see the patient is holding something that looks like a nurse call button. It's virtually the same. And the patient can deliver narcotics to himself or herself when it's needed. So they can push the button, they get a dose of narcotic, and you must think to yourself, well, isn't there a chance you're going to overdose with that? Well, it's based on a microprocessor. It's based on metabolic and distribution rates for the normally used narcotics. And we always have a lockout period built into the system. So if you push the button multiple times, you will only get one dose of the drug until such time as the lockout period has passed, at which point another push of the pump will give you another dose. It works really well. It works extremely well, and patients like it because they feel they have some control. One of the things I always advise patients using patient-controlled analgesia is don't wait until the pain's bad. Don't be stoical. Get on top of it right away, take the drug early, control the pain, and push the button whenever the pain is there. So let's talk a little bit about drug tolerance and physical withdrawal, because there's huge misunderstanding of this issue. Drug tolerance is the need of an increasing dose of drug to produce the same effect. And it's universal amongst opioids. In fact, with remifentanil, which is this very short-acting drug, we can actually see tolerance developing as we deliver it over a period of minutes to hours. Tolerance is universal. You will get tolerance to these drugs. I get tolerance to these drugs if I take it. All patients on opioids display physical withdrawal when they've been on these drugs and develop tolerance, when the drugs are discontinued. And that withdrawal is associated usually with nausea, sweating, sometimes anxiety. It tends to be fairly short-lived, and people get over it and don't need further drugs. But about 10% of individuals who develop tolerance and are likely to show signs of physical withdrawal develop a craving for the drug. And it's the craving that defines addiction. It's the going out of one's way, changing one's life, losing family, losing jobs in an effort to get more drug. That's the craving part, and that's addiction. And it's extremely difficult to deal with. It's the psychological need for a drug that has been discontinued. It's manifested by extreme anxiety, drug seeking, self-administration, and purchase of street drugs or drugs supplied by illegal methods. Withdrawal of the drug is characterized by extreme anxiety, sweating, rapid heart, vomiting, and high respiratory rate, mental confusion, or aggression, because these individuals develop huge tolerance to the drugs. They take huge doses. Physical dependence on opioids is universal and is characterized by withdrawal, but addiction and drug seeking are actually very uncommon after surgery and after most traumas. Most patients are glad to get off the opioids once they recover from their pain because they hate the side effects and they hate the cloudiness that their mind develops while they're on it. So the majority of people are not at risk of developing addiction. We're going to talk about antiemetic drugs now because postoperative nausea and vomiting is very common, but the incidence is predictable and prophylaxis is effective. So the Apfel score was developed by Dr. Apfel, who's a Swiss anesthesiologist who did a very large meta-analysis a number of years ago on the many, many trials that had been done on drugs used to prevent nausea and vomiting. And he was able to break down the causes of nausea and vomiting into 4 categories, each of which had equal importance in terms of of creating postoperative nausea and vomiting. So unfortunately for women, one of the points is for female gender. One of the points is for non-smokers. So the only thing I'm aware of where smoking actually helps you is it reduces your chances of postoperative nausea and vomiting. You get 1 point for a history of previous postoperative nausea and vomiting or a history of motion sickness. And you get 1 point if opioids are required for postoperative pain relief. And if you look at this, you can see that each of these points is worth about a 20% chance. So the cumulative effect is that if you have 4 points, you have an 80% chance of having nausea and vomiting postoperatively unless you're given prophylaxis. And we can reduce this incidence, even in somebody with a score of 4, to around a 10% chance. So it's well worth doing. The most effective drugs are 5-HT1 antagonists, ondansetron, dolasetron, granisetron, tropizatron. And patients with a cumulative AFL score of greater than 1 should receive one of these agents. So basically, in my practice, every single woman gets this drug, one of these drugs, and the one we use is ondansetron. Second level of prevention is to use dexamethasone, which by itself is not an effective antiemetic for postoperative nausea and vomiting, but in combination with a 5-HT antagonist, it actually has a cumulative effect, and it's very effective. So my actual practice, because I come from a place where smoking is extremely rare, about 8% of the adult population, is to give every woman dexamethasone and ondansetron as part of prophylaxis. If their score is greater than 3 or 4, they should be given dexamethasone, a 5-HT3 antagonist, and an anesthetic which avoids opioids. If opioids can't be avoided, try using regional anesthesia, or TIVA, with propofol. Propofol has very profound antiemetic effects of its own. Prophylaxis of PONV is more effective than treatment, so always consider adding prophylaxis to the anesthetic regimen. And interestingly, in surveys that have been done of patients, of the thing they fear most about coming into the hospital for surgery and anesthesia, number 1 in every survey that's been done is nausea and vomiting, not pain. So let's talk a little bit about some of the other drugs. The most effective anti-anxiety medications we have are benzodiazepines. These are drugs such as Valium is the one that people remember. That's an older drug. Currently, we use midazolam and lorazepam primarily. We used to use these drugs as part of a pre-med before the patient came to surgery, an hour or 2 before surgery. But this has largely been abandoned, as much to everyone's surprise. Patients found the sedation and the often accompanying amnesia associated with these drugs to be unpleasant. With very anxious patients, a drug such as midazolam will bring some relief prior to induction of anesthesia. Plus, the amnestic effect, usually associated with the medication, may reduce the possibility of recall during anesthesia. These agents are generally utilized as sleep aids or anti-anxiety medications and are not widely used for patients who are going to receive general anesthesia. They are very effective, however, improving anxiety levels when patients are undergoing regional anesthesia or surgery under local anesthetic injection. So we're now going to talk about local anesthetics. Local anesthetics are used both in just infiltration of the skin or other tissue areas so the surgeon can work on them, but more commonly are used in a regional format where a block is used to anesthetize a group of nerves, a plexus of nerves, so that more than one area is affected at the same time. So when the dentist gives you local anesthetic in your mouth, he or she is actually not just infiltrating the gums. They're actually blocking a series of nerves that enter your face, and that's a regional block. That's not really a local infiltration. So your whole face is numb, not just one tooth. Ester local anesthetics are the oldest of these drugs, and they include drugs such as cocaine. Yes, it's a local anesthetic. Procaine, tetracaine, and many others. They are characterized by having an ester link that is metabolized like succinylcholine by pseudocholinesterase. So they're broken down by pseudocholinesterase. They often have a core configuration of para-aminobenzoic acid, PABA, same as sunscreens. And this PABA is associated with a high incidence of allergic reactions and anaphylaxis, which is the most severe type of allergic reactions. So ester anesthetics are rarely used by modern anesthesiologists. The other type of local anesthetic is an amide local anesthetic, and this is the more modern type of drug. And you can always differentiate between an ester and an amide local anesthetic by knowing its generic name. If there is no I before the cane in the generic name, it's an ester. If there is an I, then it's an amide. So think of lignocaine or lidocaine. I comes before cane. Ropivacaine, there's an I before cane. Bupivacaine, there's an I before cane. Cocaine, no I before cane, so it's an ester. Amide local anesthetics such as lidocaine, which is also known as lignocaine, bupivacaine, ropivacaine, mepivacaine, and others, are preferred for regional anesthesia of all kinds because they are predictable in their onset and duration of action, and they virtually never produce allergic reactions. So in summary, in this lecture, we've talked about the management of acute pain, surgical pain, trauma pain. We've talked about addiction and tolerance to opiates. We've talked about sedation with sedating drugs. We've talked about the incidence and the treatment or prevention of postoperative nausea and vomiting. And we've talked a little bit about regional anesthesia, and we'll talk more about that in a future slide. All the drugs that I've mentioned must be well recognized by every anesthesiologist, who must, in addition to understanding how to use them, understand the potential for side effects and how to manage side effects when they occur.